COVID, so we could only do very few physical activities, but I thought that the last day should be at least hybrid. So we made this, attempt to do it. And I welcome Team MAMC led by Asmita and with her able team who are going to, take AOGD to greater heights now. And we will have the handing over ceremony after the monthly meeting. So I request Dr. Anjali to start the proceeding of the monthly meeting. Become so used to the webinars. Before the meeting, we'll have the secretary's report. So our joint secretary, Dr. Divya, kindly come and give the secretary's report.
So, good afternoon, everybody. I will be presenting the secretary report on behalf of Dr. Monica Gupta. She's on the way. She will join us soon. So, we started this with the clinical meeting at UCMS and GTB Hospital on 25th of February, where interesting cases were discussed. This month, we had a lot of online and offline webinars and CMEs. So, on 9th of March, AOGD celebrated International Women's Day at Indian Habitat Center. We had AOGD workshop on critical care obstetrics at Safdarjung Hospital on 12th of March. Then AOGD WHO Foxy training on respectful abortion care was conducted on 16th of March. Then contraceptive update with South Delhi district at Safdarjung Hospital was conducted on 29th March. We had CME on fetal-maternal infections prevention and care with Society of Fetal Maternal Medicine Delhi chapter yesterday only. Then we had International Women's Day celebration PAN-DGF with AOGD on 8th March, and the theme was gender equality. We had webinar on adolescent health medical concerns by Sir Gangaram Hospital under AOGD ages on 9th of March. Then we had this webinar on eye care for contraception by Family Welfare Committee on 1st March. We had CME on PCOS by Foxy Endocrinology Subcommittee in association with AOGD on 23rd of March. We had two public forums, one on PCOS, which was on 1st of March, second was on menopause, 17th March. Both had live streaming on the social media. Then we had this AOGD PG forum class on endometriosis on 21st March. AOGD Oncology Subcommittee conducted these webinars on ovarian and breast cancer conclave on 26 February and on towards elimination of cervical cancer on 19th March. AOGD Oncology Subcommittee, we conducted Women's Cancer Screening Fortnight, which began on International Women's Day celebration on 8th of March and continued till 21st of March. AOGD Multidisciplinary Committee conducted webinar on PPH on 28th February and another one on RH negative pregnancy on 22nd March. Then there was a webinar conducted by AOGD Urogyne Committee on anorectal physiology for the gynecologist on 5th March. We had two more interesting webinars by AOGD Genetics and Fetal Medicine Subcommittee on case-based discussions in fetal medicine on 10th March and inverting the pyramid of antenatal care, which was in association with Maulana Azad Medical College and SFM Delhi chapter on 12th of March. Then AOGD Endoscopy Subcommittee conducted masterclass on robotics in gynecology with IH Delhi chapter on 24th March. AOGD Infertility Committee They conducted this offline CME on 29th March on endometriosis, which was well attended. We had a AOGD executive meeting on 31st of March, yesterday only, where we decided date and venue of the next year's conference. The date has been decided to be on 12th and 13th of November 2022 at Indian Habitat Center. 20 lakh interest free loan will be given by AOGD corpus, which will be refunded after the conference, and income account statement was presented and it was passed by the executives. So these are our forthcoming events. There will be a CME by Breast and Cervical Cancer Screening and Awareness Subcommittee on 5th April. On 16th April, there will be a webinar on childhood to adolescence by Rural Health Subcommittee. There will be a PG forum on hypertensive disorders of pregnancy on 18th April. CME on induction of labor by Safe Motherhood Committee on 25th April, and CME by Oncology Committee on 30th April. And the next AOGD monthly clinical meeting will be held at Lady Harding Medical College on 29th April 2022. Thank you. I invite Achla ma'am for the further proceedings.
We are proceeding with the scientific session, and we will be presenting 4 interesting cases covering a wide spectrum. Questions will be answered after all the 4 cases are presented. The first case is an interesting case of a young girl with hemoperitoneum, and I invite Dr. Ziba, Dr. Rekha, and Dr. Jyotsna to present it. So we are going to present an interesting case of hemoperitoneum in a young girl, and Zeba will be talking about the history and examination finding and initial management of the patient, and then we'll discuss why we chose this case to be presented here. So this was actually a 14-year-old adolescent girl who came to our hospital. She was admitted in emergency as a case of diarrhea and acute abdomen. And this patient actually had an initial report of MRI, which was done around 2 weeks back, which showed ऐसे ही कर दो कोई बात नहीं इस वाला खोल लो
Good morning, everyone. This patient was a 14-year-old girl who presented to the emergency department with acute abdominal pain, intractable diarrhea for 2 to 3 days, cyclical abdominal pain for 18 months. She had not attained menarche yet. On examination, she was dehydrated. Blood pressure was 82 by 52 mmHg. Heart rate was 130 beats per minute. Shock index was 1.54. Systemic examination was normal. Breast and pubic hair development were TANF stage 3. On per abdominal examination, abdomen was distended, tense, tender, rebound tenderness was present, and bowel sounds were hyperperistaltic. On local examination, vaginal introitus was absent and replaced by pink mucosa. Urethral meatus and anal opening were in close proximity to one another. On per rectal examination, no fullness was felt. Now, this is the image arrow showing absence of vaginal introitus. On ultrasonography, there was moderate intraperitoneal fluid collection suggestive of hemoperitoneum. On investigations, hemoglobin was 9 gram per deciliter. Patient had hyponatremia and hypokalemia. Kidney function tests were markedly deranged. Creatinine levels was 5.5 milligram per deciliter. Lactate levels were elevated 4.6, and ABG was suggestive of metabolic acidosis. Now we found an MRI which was done 2 weeks ago, and it was suggestive of a massive hematocolpometra with bilateral hydroureteronephrosis. The size of the hematocolpometra was 20 into 12 into 10 centimeter. The images showing the same. Patient was taken for an emergency laparotomy. On intra-op, 900 cc of dark blood was drained. 2 rents were seen in the upper 1/3 of the posterior vagina with smooth, non-bleeding edges. Uterus was bulky. External surface of uterus was smooth without any rents. The arrows are showing rents in the posterior vagina. A pull-through vaginoplasty was performed through an abdominopelvic approach. Incision was given at perineal end in the area of introitus between urethral and anal opening. 4 centimeter of distal atretic vagina was dissected under guidance of fingers placed in proximal vagina and rectum. Proximal vagina was mobilized and affixed to introitus. Cervix was felt high up as a dimple on per vaginal examination. A syringe mole wrapped around a modeling wax was introduced through the introitus. Now, this was the modeling wax we used during our surgery. We wrapped it around a syringe. So the final diagnosis was spontaneous hematocolpos rupture secondary to distal vaginal atresia with acute kidney injury. In post-operative period, she required several days of ICU care. Her kidney function tests gradually improved. Mold change continued weekly. She developed abdominal surgical site infection and pelvic vein thrombosis, which were managed. She was discharged on post-op day 28 with a vaginal mold in situ. However, she was lost to follow-up during the COVID pandemic, and she returned after 6 months with vaginal stenosis and pyocolpos. The stenosed portion of vagina was resected, and foul-smelling purulent fluid around 200 cc was drained. Cervix was neither felt nor visualized this time, and so it was a false vaginal passage. Patient was started on antibiotics and planned for a second procedure after resolution of infection. In the second abdominopelvic surgery, it was done along with plastic surgeons. Abdominal cavity was opened, base of bladder was separated from cervix and upper part of vagina. 1 centimeter of incision was given across anterior vaginal wall distal to cervicovaginal junction, and a 10 number Higgins dilator was introduced through it. Another incision was given at perineal end. Fibrous band of tissue between proximal and distal false vagina was dissected using the dilator as a guide. The image showing the same. A is the point A is point which is showing the upper level of dissection, and B is the point showing the lower level of dissection, and the bubble, the yellow bubble which you can see, was the space of collection. A split thickness skin graft was placed over the foam vaginal mold, and it was positioned over raw edges of the vagina. This mold was replaced after a week. Patient was discharged on day 10 with a custom-made silicone vaginal mold, which she could clean and self-insert. Now, 3 weeks later, the grass assimilation was almost complete except for few islets on posterior and posterolateral aspects. You can see in the arrow well-made vaginal introitus. And after 6 weeks, the graft was seen covering lower 5 centimeter of distal vagina. She continued to have a white patent vagina and normal menstrual function at 6 months. Ultrasound repeated at this time depicted normal cervicouterine and renal architecture. Now I'd like to hand over to Dr. Rekha ma'am for the discussion part.
So
coming to the discussion, it is actually, we all think that hematocolpus is an emergency and we try to pose the patient as early as possible. But the recent ACOG committee opinion also says that you should never consider hematocolpus as a surgical emergency, because you have to well plan the surgery and it has to be done by multidisciplinary team approach. Although the case was different in our patient, because she presented as acute abdomen, so we had to take her up for laparotomy immediately without being well prepared to manage her. And it is recommended that till the time patient attains maturity to manage herself with the patency of the vagina, you should suppress the menstruation of the patient and then plan it at a time when patient is sufficiently mature to understand that the vaginal passage has to be maintained patent. So this can be achieved by giving hormones in these patients. So this case we actually took to present at this forum because we did not come across any case of hemoperitoneum secondary to rupture of hematocolpus. There have been cases of rupture of hematocolpus, but which is through the introitus, especially in cases which are because of the imperforate hymen. And there is one case of rupture of this hematosulping. So this was a case report where they showed that because of the hematocolpus, there was rupture of the hematosulpings. But we have not yet seen any case report where there was rupture of the vagina, which was seen in this patient. So this is something, which has to be kept in mind, because this patient had MRI done 2 weeks back. Otherwise, we could not feel any bulge in the vagina. So that would have gone missed. Like we might have delayed her treatment had we not released the MRI report. So we all know that these pull-through vaginoplasty is actually the treatment of choice for patients who have vaginal atresia. If the thickness of the atresia is more than 3 centimeters, then you should always put the graft. In our patient, the thickness was 4 centimeters. So ideally, we should have put the graft there. We had actually planned to put it after the initial surgery, but just because patient developed pelvic thrombosis and she was started on anticoagulant, so we could not do the surgery at that time. And after that, we lost her to follow up.
And what other
Take-home message is that spontaneous rupture of hematocolpus into the abdominal cavity is a rare manifestation of vaginal atresia. And the best long-term outcome in these cases are achieved with clear understanding of the anomaly and mobilization of the appropriate surgical resources, and sufficient pre-operative, post-operative counseling and planned surgical interventions are the key to success. Thank you so much.
Thank you, Dr. Rekha. And we all face dilemmas when we encounter young girls with an ovarian mass, mostly related to how we will manage their fertility issues. So we will discuss 2 such interesting cases today. The first by Dr. Nalini, Dr. Sarata and Dr. Renu. And the second will be presented by Dr. Shivani and Dr. Sarata Shamsundar.
Good afternoon, everyone. Hollowing out the jelly belly. Let's see why our case is titled so. My patient, 25-year-old, came with complaints of abdominal discomfort for 4 months, distension for 2 months, and dyspepsia and loss of weight for 1 month. She was an early gravid woman, married for 3 years, with no significant menstrual, past, or family history. On general physical examination, her vitals were stable. There was no palpable lymphadenopathy. Breast and thyroid examination was normal. Systemic examination revealed no positive findings. Abdominal examination, there was uniformly distended along with fullness of flanks, and there were no scars or sinuses seen over. There was no tenderness felt on palpation. A large mass measuring about 24 into 26 centimeters, smooth surface, probably arising out of pelvis, was palpated, and there was no evidence of free fluid on percussion. Per-vaginal examination revealed uterus couldn't be felt separately from the mass, while the bilateral fornices were full. Her pre-op investigations were within normal limits. Her tumor markers CA125, CEA, and CA99 were all elevated. Ultrasound whole abdomen and pelvis shown a large abdominopelvic cystic structure measuring about 15 into 14 into 7, abutting the uterine fundus and right ovary with multiple internal septations with no significant vascularity within. There was no ascites, no lymphadenopathy. MRI abdomen confirmed the ultrasound findings, probably suggestive of cystadenoma. Her ultrasound was repeated after 2 months from the previous imaging, which shown the same findings with a notable additional finding known as arborization pattern as seen in the picture with central core showing vascularity. Bilateral ovaries were not seen separately and there was no ascites. CT perfusion scan was conducted to know the vascularity of the septations, which revealed there was no vascularity as seen in the picture. Her upper GI endoscopy and colonoscopy was carried out in view of RISE CA and CA 199, and also patient had dyspepsia, which came out to be normal. And so we posted her to staging laparotomy with intra frozen section on 24th of February. To our surprise, on opening abdomen, there was abundant gelatinous material occupying the whole abdomen and pelvis as seen in the picture. Further, a large multicystic right ovarian cyst of size 22 into 26 centimeter having multiple internal septations, multicystic with multiple breaches in the capsule was removed and it was sent for frozen section. Frozen section, however, revealed mucinous cystadenoma, which was benign. As the report was benign and the patient was nulli gravida, we proceeded with left-sided ovarian cystectomy, which was 10 into 11 centimeter, having appearance almost similar that of right-sided, leaving behind a 4 into 3 centimeters of ovarian remnants. To our surprise, we found appendix, which was enlarged, tensely cystic, 6 into 3 centimeter, having multiple mucinous deposits over it, and hence appendicectomy was carried out. Further, mucinous deposits were also seen over pouch of Douglas, uterosacral ligaments, also over the omentum, and hence omentectomy was done, and it was sent for osteopath examination. Her postoperative period, when uneventful, gross specimen appears as shown in the picture, and microscopic appearance revealed multiple internal septations with accumulation of mucin within the ovary. Her final histopath report came out to be mucinous cystadenocarcinoma of right head neck cell mass, left ovarian cyst, as well as that of appendix. Immunohistochemistry revealed positivity for CK20 and CDX2, while negative for CK7, suggesting of it was a primary appendiceal tumor having grade of T4B, well differentiated grade 1 mucinous cystadenocarcinoma involving the surgical margins along with metastasis to ovary and omentum. To know any other elsewhere lesions in the body, we carried out PET CT postoperatively, which shown no other hypermetabolic lesions. Tumor markers, which were carried out 1 month post-surgery, reveal decrease in all the markers with notable marginal decrease in the CA, which was just from 103 to 96. So this is how, in the process of hollowing out the jelly from belly, we found the culprit to be appendix.
So after fishing out the appendix from the jelly belly, we fished out some interesting literature about pseudomyxoma peritoni. So it's an entity with it's a clinical syndrome, which is fatal, and the incidence is 1:3 per million, also fancily called jelly belly. The 95% of PMP are appendiceal neoplasm. They're mostly asymptomatic, but it can be found at cross-sectional imaging, laparoscopy, or laparotomy. Presentation can be variable, sometimes asymptomatic, most common being abdominal pain, bloating, and distension. Appendiceal neoplasm are primary, so the primary malignancies are very rare, around 0.4% of GI tumors, and cystadenocarcinoma, which is our case, is second most common of appendiceal neoplasm. The age group is 55 to 70. They mimic primary ovarian malignancies and can present a diagnostic challenge. And ascites leads to gradual accumulation and suppression of the digestive tract, so the patient can succumb to malnutrition. So how our case is peculiar? The review of literature since January 21, we found 23 cases. Only 1 out of them was found to be serocystadenocarcinoma, and that 2 patient was 70-year-old. Appendiceal mass was not picked up by any of the imaging. Frozen section and scrape cytology both revealed benign pathology, and arborization pattern seen in the peritoneal cavity was not familiar to gynecologists as well as the radiologist. And nulli gravida status of the patient was posing all the more management dilemmas. So on further search, we found a robust review of literature by European Journal of Surgical Oncology, and which they asked the worldwide PNP expert to give their recommendations, and they followed the PSOGI consensus 2016 for appendicular neoplasm, in which our patient fitted into mucinous adenocarcinoma without signet ring cells and T4B. So they recommended regarding the tumor markers, regarding the management, and regarding the imaging. Among the tumor markers, CEA and 99 were mandatory in all cases of PMPs, and CA125, if there is an ovarian neoplasm or an adnexal mass, is compulsory. Another important thing we found was a ratio of CA125 to CEA. If it is more than 25, it is more suggestive to be primary ovarian rather than metastasis from GI. Other recommendation, they don't comment about ultrasound, but CT according to them is preferred out of all the modalities, but the sensitivity of CT goes down as the size of the lesion reduces. The MRI, they say, is only good at expert hands, and FDG PET does not have a good sensitivity for mucinous masses. So among the management recommendation, any patient who presents with mucinous adenocarcinoma should go ahead with hemicolectomy, complete cytoreductive surgery, and HIPEC. But in young patients, fertility preservation options, before she goes for CRS and HIPEC, we can go for cryopreservation. And in reproductive age group women, after prior counseling about the extent of the disease and the preoperative tumor markers, we can counsel them about their reproductive potential and preservation surgeries. So the blue highlighted portion is the workup for PMPs as highlighted by the authors of this journal. They say that take a proper history and evaluation and tumor markers. And if you don't find adnexal mass on imaging, then go ahead with laparotomy. And on laparotomy, if you think it is resectable, then go for CCRS and HIPEC. That is complete cytoreductive surgery and HIPEC. So the recommendations for follow-up are during the first 2 years, physical examination every 6 months, CT every 6 months, and tumor marker for every 6 months. For next 2 years onwards, physical examination every 6 months to 1 year, CT yearly, and tumor marker 6 monthly. So the 5-year survival rate is quite dismal. So patient with debulking without adjuvant therapy, the survival is only 15 to 67%, but with CRS and HIPEC, it rises from 74 to 87.4%. So the dilemmas are, because of the rarity of the condition, the RCT are not possible, nor likely to happen in future. So there are still many questions which are unanswered. And there is disagreement in literature regarding the management of premenopausal women. So the take-home message is arborization pattern on ultrasound in the peritoneal cavity should ask us to seek for appendicular mass. Assessment of appendix is paramount importance in case of mucinous cancer. And nulliparous women, it's not going. In nulliparous women, preservation of childbearing function can be considered after counseling regarding prognostic factors and progression of the disease. By this case, we added drop to already scanty literature, which is available regarding PMPs. Thank you.
Good evening, everyone. Today, I, Dr. Shivani Verma, Senior Resident at Safdarjung Hospital, along with Dr. Sarita Shamsundar, will be presenting a case of ovarian mass in pregnancy. Mrs. N, a 29-year-old lady, gravida to paravan Livan, came to antenatal OPD at Safdarjung Hospital with the complaint of amenorrhea for 6 months, loss of appetite, nausea and vomiting for 7 days, pain lower abdomen for 2 days associated with fullness. There was no significant past and family history. Her general physical examination was normal. On per abdomen examination, the uterus was corresponded to 30 weeks period of gestation. Uterus was relaxed. Mild tenderness was present in the infraumbilical region. Imaging was done which showed an ultrasound pelvis, which showed a single live intrauterine fetus at 17 weeks, 1 day period of gestation, with the right adnexa showing a large cyst of 21 into 16 centimeter. MRI was advised as ultrasound findings were equivocal. MRI revealed a large solid cystic lesion in the right adnexa lying superior to the pregnancy, intrauterine pregnancy abutting the fundus, and a similar lesion was seen in the left adnexa measuring 4.5 into 4 into 4 centimeter, which was suggestive of bilateral ovarian cystic neoplasm with features of malignancy. The tumor markers showed CA125 was raised 50.6 and serum LDH was raised 523. Rest of the tumor markers were normal. The diagnosis, working diagnosis was made to be gravid to paravan liven at 19 plus 4 weeks period of gestation with bilateral adnexal mass likely malignant. The case was discussed in our tumor board meeting and the counseling was done and decision for surgery was taken. Staging laparotomy with bilateral salpingo-oophorectomy and infracholecommentectomy was done. In the pair of findings, the uterus corresponded to 20-week size and the right side mass completely merged with right ovarian tubes of size 15 to 20 centimeter, which was sent for scrape cytology and was suggestive of borderline serous cystadenoma. The left side mass was 5 into 5 centimeter and sent for cytology suggestive of malignant epithelial tumor. Small deposits present on the posterior surface of the uterus were biopsied. No enlarged pelvic or para-aortic lymph nodes on palpation. Bilateral salpingo-oophorectomy was done and infracholecommentectomy was done. This is an image showing the right ovarian mass and the left ovarian mass, which was 5 into 5 centimeter. The post-op diagnosis based on the histopathology report was gravid to paravan liven with 21 weeks with bilateral serous papillary cyst adenocarcinoma, and as the uterine deposits also tested positive for malignancy. The stage was FIGO stage 2A. In the post-op period, the patient was counseled for chemotherapy, and after understanding the benefits and the risk, she was willing for chemotherapy after delivery. She followed up in our antenatal OPD and progesterone support was given. She went into spontaneous labor at 39 weeks and delivered a healthy male child of 3 kg. In the postpartum period, she received 6 cycles of chemotherapy, injection paclitaxel and injection carboplatin over a period of 6 months, and baby was on top feeds. Post-chemotherapy imaging relieved a small 1.2 into 1 centimeter size cystic lesion in the left ovary with no abnormal enhancement, no obvious residual disease, and CA125 was measured to be 27.2 units per ml. Completion surgery was done on 21st January 2022, and the Pura finding showed a uterus which was normal size with 2 small cystic nodules of size 3 into 2 centimeter on the right corner, which was filled with clear fluids. No enlarged pelvic or para-aortic lymph nodes, no ascites, and no peritoneal deposits. The patient was followed up with the histopathology report of his uterus with cervix, which revealed chronic cervicitis with coilocytosis, disordered proliferative endometrium, and unremarkable myometrium. Presently, the patient is under follow-up in our gynecologic oncology OPD and medical oncology OPD, and her CA125 as of 20th February is 20 units per ml. Now, I'd like to call Dr. Sarata for continuing the presentation. Thank you.
Good evening, everyone. This case actually was, for me, it was the first time that we encountered such a case, and thanks to Dr. Sunita Malik, she was the head of the unit at that time. So we managed to arrive at a consensus, got the tumor board meeting and got consensus of even experts all over the country. So ovarian cancer in pregnancy is very rare. 1 in 18,000 pregnancies is complicated by an ovarian malignancy. And out of all the ovarian neoplasms that you find in pregnancy, 2 to 5% of them are malignant. So there are problems in making a diagnosis of ovarian cancer in pregnancy because tumor markers are elevated, like the alpha fetoprotein, beta HCG, CA125, all of them are routinely elevated in pregnancy. And inhibin, B, AMH, HE4 are not elevated in normal pregnancy and are useful for diagnosis and treatment. And MRI is useful to differentiate ovarian from extra ovarian masses. And when there is a doubt about what is the nature of the mass on ultrasound, then one should go for MRI. And concurrent pregnancy actually does not affect the ovarian cancer progression. So it does not increase the growth rate or make it more aggressive. So when you find an adnexal mass in pregnancy, and if the patient is symptomatic, then she goes for ovarian cystectomy if it is suspected to be benign. But if you find that there are suspicious features, there are with solid component, or there is an increase in size, or there is increase in vascularity, then you should go for a unilateral adnexectomy with frozen section or scrape cytology with preservation of uterus and contralateral ovaries permissible in most cases of clinically apparent early stage disease. And even chemotherapy can be given during pregnancy also, up to 34 to 36 weeks, and deliver as per obstetric indications. And postpartum, you do the completion surgery. Whereas if the mass appears if there is, it does not appear to be suspicious, and it is asymptomatic, and the patient is asymptomatic, then you can go for serial ultrasound and deliver for obstetric indications only. And if you're doing cesarean, then at that time you can evaluate the mass. So the principles of surgery for ovarian tumor in pregnancy is in second trimester, and especially after 16 weeks, surgery is safe. And you try to not manipulate the uterus and remove the mobile intraperitoneal deposits. And if malignant, even systemic chemotherapy can be given in the second and third trimester in a neoadjuvant fashion. Like suppose it is diagnosed in a advanced stage 3C, then you can just go for chemotherapy in pregnancy and do surgery after delivery. And interval cytoreductive surgery after delivery using the same chemotherapy drugs can be used. And if suppose you diagnose in the first trimester and you find extensive disease, then or stage 3 and it is operable, then she can go for hysterectomy with the fetus in situ in conjunction with tumor debulking. Chemotherapy in pregnancy is also safe. In the first trimester, if you do encounter a case, then consider pregnancy termination followed by chemotherapy, and if chemotherapy can be delayed up to second trimester, that should be done. Whereas if you're diagnosed in the second trimester, then chemotherapy is safe. Whereas diagnosed in the third trimester and she's less than 32 weeks, then go for chemotherapy. Whereas if she's more than 32 weeks, then the option is either consider delaying chemotherapy until term or near term, or consider delivery. And if in the postpartum period, chemotherapy can be given, but breastfeeding should be avoided. So the obstetric outcome, mainly since they are high risk pregnancies, multidisciplinary approach is needed. Prematurity and fetal growth restrictions is more common when cytotoxic treatment is given during pregnancy. And because this prematurity contributes to cognitive and emotional development of children, guidelines advise, so as you should try and deliver at term and not try to deliver preterm. So, and then the role of genetic testing for her, because she's only 25, that is what is her risk if she is gene positive. She is at risk of breast cancer and colonic cancer. And also for the genetic testing of family members will be required. So therefore, we have referred her to the hereditary cancer clinic at AIMS, IRCH AIMS. Now, what about the other question is, can we give HRT after bilateral Sulping Gopherectomy? So the recommendation is if it is not non-granulosa cell tumors, then the HRT can be given, estrogen alone if hysterectomy has been done. But if hysterectomy uterus is intact, then both estrogen and progesterone can be given. So both for ovarian and endometrial cancer survivors, HRT does not seem to be associated with increased risk of recurrence, especially if used for a short-term period. So the take-home message is ovarian tumors in pregnancy, we do see quite commonly, but it's better to get imaging done by an experienced radiologist. And if you find ovarian cancer, then surgery and chemotherapy in the second trimester is safe. Multidisciplinary approach is needed, and aim for delivery at term followed by completion surgery. Counseling the patient and family for genetic testing and follow-up. So this patient we had to really counsel, because during pregnancy, when we were going for surgery, the husband actually wanted hysterectomy and everything done at that time. But then after extensive counseling, then they agreed to have only a bilateral adnexectomy. And HRT for a short period is safe in non-granulosa cell tumors. Thank you so much for your patient hearing.
Thank you, Dr. Sarita. I now invite Dr. Suchanna, Dr. Sumitra, and Dr. Renu to present intricacies of solving this jigsaw puzzle of fetal anatomy.
So very good evening and warm welcome to everyone.
So we will be sharing our experience on a very interesting topic, that is fetal autopsy, a piece of the jigsaw puzzle. So the term derived from the Greek word autopsia, meaning to see for oneself. The first real dissections were carried about 300 before current era by the Alexandrian physician Herophilus and Erasistratus. Even Leonardo da Vinci dissected 30 corpses and noted abnormal anatomy. It aids in the diagnosing the etiology in nearly half of the cases of MTP done for anomalous fetus or unknown stillbirth. It specifically helps us when there is suspicion for any genetic etiology or where the prenatal samples are not available or parents refuse for any prenatal testing. It adds to the information obtained during antenatal workup such as imaging, prenatal test, or infection screen. After taking informed consent, the fetus is placed upon a clean sheet. Length, weight, and any external anomaly are looked for. We take the photograph from the front, back, and sides. A Y-shaped incision is given over starting from both the clavicle and extending downwards. We first enter the abdominal cavity, open it, and all the viscera are examined regarding its position, normal size, anatomy. Then we enter the thoracic cavity for the same. Whichever tissue we want to send for histopathology or we want to preserve, we take that, and the skin is closed. Then with sutures, fetus is wrapped and handed over in a dignified way to the respective guardian. Now coming to our cases, the first case is 28-year-old gravid to abortion 1 who came to our fetal medicine OPD at 19 weeks of gestation with ultrasound report suggestive of fetal hydrops. On taking history, similar ultrasound findings were there in the previous pregnancy also, which were suggestive of fetal hydrops. That pregnancy was terminated, although no photographs of the baby was preserved and no prenatal testing were done. We did the ultrasound. It showed scalp edema, presence of ascites, fetal anemia, and placentomegaly. We counseled the couple. They actually agreed for termination and agreed for autopsy. Followed by that, we took the amniotic fluid prior to the termination and saved for any required prenatal testing. When we did the autopsy, it was the look of the fetus, which was hydropic. Ascites and pleural effusion both were present. Liver appeared enlarged to us, and no other external anomaly were found. We preserved the photographs. Fetal liver, kidneys, and heart were sent for histopathological examination. Fetus were handed back. So when the histopathological report came, it was suggestive of mucopolysaccharidosis involving the great vessels and heart. We ordered a clinical exome. It revealed that there was a mutation in the GUSB gene, which was likely pathogenic for the disease mucopolysaccharidosis type 6. She was counseled that as it is an autosomal recessive condition, there is a 25% risk of recurrence, and she should follow up with us in every pregnancy. In next pregnancy, she followed up with us. Chorionic villus sampling was performed at 12 weeks of gestation, and Sanger sequencing was performed. It revealed that the fetus is this time heterozygous with, and it is a carrier but not affected. She continued with the pregnancy. She followed up with us regularly. Anomaly scan was normal, and at term she had an emergency cesarean section done in view of fetal distress and delivered a healthy baby of 2.8 kg. Both the parents. And fetal skin we preserve for later required testing. The histopathological report revealed features of polycystic kidney disease, and on clinical exam also it was confirmed that it is a type of PKD, AD-PKD, and again we counsel the couple for need of carrier screening. The mother was unaffected, however the father was found to be heterozygous for the disease. It is indeed a rare phenomena that the fetus will be affected in AD-PKD, so the raw data of the fetal genetic analysis is preserved, and we are analyzing it for any other mutation. So she was counseled that they should follow up with us or any genetic clinic for future pregnancy. Coming to our last case, she was also a gravid to abortion one, presented to us at 18 weeks, 3 days of gestation. In previous pregnancy, also she had a termination done due to gross congenital anomaly. The fetus had bilateral enlarged kidneys, right subclavian artery, and no photographs were preserved, no genetic testing were done at that time. In this pregnancy also, there was grossly enlarged kidneys, non-visualization of stomach bubble, bladder, and there was anhydramnios. So this couple also opted for termination. We did the autopsy. On opening up, there was a bilateral enlarged kidney seen, and we sent it for histopathological examination. However, no other anomaly we could find. Then on histopathological examination, polycystic kidney disease was there, features of polycystic kidney disease, and they identified tiny liver cyst, which we couldn't find in our naked eye examination. We ordered a clinical exome, and actually PKD type 4 that can present with or without hepatic disease, and renal tubular dysgenesis were two autosomal recessive condition identified, which may be the underlying genetic cause in this case. So she was also counseled regarding couple carrier screening, and she should follow up with us in the future pregnancies. Now I invite Dr. Sumatra Vachani to conclude this talk.
Good evening, everyone. So couple of years back, when we expanded the fetal medicine to an invasive genetic clinic, the challenge we faced was that we would be getting patients who had a recurrent fetal affliction, but they were not carrying any reports of their previous pregnancies. There was no ultrasound imaging, no prenatal test had been done. So we were clueless at that time, and they couldn't even afford, the cost factor was also inhibiting us. So that time we started this doing fetal autopsies in fetal medicine, and we saw that it had so many advantages. Autopsy gives us the opportunity to confirm our finding by looking at it. Histopathology can aid us in diagnosing the case, and above all, we can get certain pointers, because then we can order for a very targeted sequencing test. We need not go in for a generalized kind of a test. So that was one very big factor which helped us to take this forward. So we've been able to do around 15 to 16 cases by now. And the challenges that we faced are that, there is still some prejudice regarding autopsy. People want to take the babies back. And so thorough counseling and a lot of dedication is required. And of course, the time of delivery, because the termination can happen at any time during the day or night, and the fetus has to be kept in saline before, and autopsy has to be done on time. And of course, after the autopsy, everything has to be, given back. The baby has to be given back in a very dignified manner. And we needed to coordinate with the pathology department to give us the reports in time so that we could go ahead with further testing. And it really helped us, because then we could order that very specific test, and we could help out our patients in this manner. And so I would like to really share that all pregnancies which are undergoing termination for births, please, they should be evaluated. All anomalous features should be noted, and photographs should be taken front, back, and the side. An infantogram is very important, as it can aid in the diagnosis, especially in cases of skeletal dysplasias. And anything we can take an umbilical cord sample, a placental sample, fetal skin, and fetal blood can also be preserved. If you want to get a DNA test, then in the EDTA vial, otherwise for a karyotype in a heparinized vial for further genetic testing. And post-counseling, if the couple accepts, then of course a detailed autopsy and a histopathological examination should be done, which can aid in the diagnosis. Thank you.
Thank you, Dr. Sumitra and Suchanna. And now, last but not the least, a very interesting presentation by Dr. Harsha of an unusual case of an ovarian cyst in an adolescent girl.
Good evening, everyone. Hope my case acts as a sweet dish after a very heavy main course meal and side dishes. So I am presenting a case of ovarian cyst mimicking OHSS in a young non-pregnant female. So this was a 15-year-old female presented with complaints of heavy menstrual bleeding, abdominal distension, and severe anemia. And the history that could be noted was she had cold intolerance, easy fatigability, and a modest increase in weight gain. And the mother gave history of voice change. There was no other significant past history. She had attended menarche 2 years back with history of heavy and irregular menstrual cycles for last 1 year. She had gross pallor and pedal edema was there. The skin was dry all over the body and she was slightly on the heavier side for her age. She had vital stables and however periorbital puffiness was present. There was no thyromegaly and systemic examination was normal. There was diffuse distension over the abdomen and tenderness was present and that prevented us from doing deep palpation. On investigations, her urine pregnancy test was negative. Her hemoglobin was only 2 gram%. TLC, platelet, and INR were within normal limits. The LFT, KFT, and electrolytes were also normal. Her thyroid function test was done and it showed TSH of 413.2 and TPO was 804, T4 was 17 and T3 was within normal range. Beta HCG and other tumor markers were normal. However, the prolactin was modestly high to 24.1. LH was reduced and FSH was within normal range. Her ultrasound showed bilateral bulky ovaries. The right ovary was about 11 by 8 by 5 centimeters and a volume of 240 cc's. The left ovary was equally big and a volume of 160 cc's. There was mild ascites and there was no evidence of pleural or pericardial effusion. The uterus had the normal pubertal dimensions and the ET was 9 millimeters. Rest of the abdomen was normal on ultrasound. So this was the ultrasound picture showing the typical, this was the right ovary and this was the left ovary, which showing the typical spoke wheel appearance, which is characteristic of cystic lesions. She was managed conservatively with blood transfusions and based on the clinical lab and radiological investigations findings, the diagnosis of spontaneous OHSS like picture due to hypothyroidism was made. Endocrinology opinion was taken and she was started on thyroxine 75 micrograms per day. And she was kept for a month in the ward and then she was discharged. She was reviewed after 3 months and to all of the surprise of everyone, the TSH was repeated. It came out to be 50 and the ultrasound showed remarkable decrease in the size of both the ovaries and there was symptomatic improvement. She was again called after 6 months, that means 3 months after the first visit. Now she was totally asymptomatic. There was no excessive blood loss during periods, although there were slight irregularity in her menstrual cycles. She is still continuing with thyroxine and her TSH has come down to 2.6. So a little bit about the pathophysiology. In the pubertal age group, the excessive production of the less potent estriol, it leads to the decreased feedback regulation, resulting in excessive gonadotropin release. And particularly in females with hypothyroidism, since they have high levels of thyroid stimulating hormones, they can directly stimulate the ovaries is one of the hypotheses. The other is there are mutations of the FSHR gene that can cause ovarian hyperresponsiveness. Also, there is altered estrogen metabolism and there is defective hypothalamic pituitary dysfunction along with deranged prolactin metabolism, which can give rise to such polycystic ovarian picture. One of the studies when reviewed quoted that there's a strong immunostaining of TSHR, TR alpha 1 and TR beta 1, which was demonstrated on the ovarian surface epithelium. And this ovarian enlargement in severe hypothyroidism is probably due to the stimulation of FSHRs by unusually high TSH level. This has a weak FSH-like activity also. And it has been shown that TSH could interact directly with FSHRs to elicit gonadal stimulation, leading to such a clinical presentation of the ovarian configuration. So this case describes association of primary hypothyroidism with OHSS-like presentation. And the take-home message is Thyroid function tests should always be done in young females who present with menstrual irregularity and ovarian cysts on ultrasounds. And timely diagnosis and management of hypothyroidism is very important in young pubertal age group females with abnormal uterine bleeding with ovarian cysts. So this was a rare presentation. Thank you.
Dr. Harsha. Now I invite the judges, Dr. Ratna Biswas, Dr. Neeta Misra and Dr. Anita Rajoria to question the presenters, and they will answer your queries.
Ma'am.
Starting this one, that hematocol. Was there any specific cause that
Actually, we could not think of any cause why the vagina had given way. And as we had shown in the picture also, the margins were not fresh. Actually, patient had acute abdomen 2 days before coming to us, and she had diarrhea. So diarrhea, whether it was because of the blood irritating, and that's why she had diarrhea, because the diarrhea was so severe that she had gone into acute kidney injury because of the diarrhea. Because the hemoperitoneum which was there was only 900 ml, and it was all altered blood. So there was no fresh blood which was lost. So it was basically her, the shock index also was raised because she was dehydrated and she had dyselectrolemia also. So we could not actually think of any cause which could have led to spontaneous giving way of this thing. Yes, one thing was definitely there, that her tubes were not that dilated. Hematosulpings was not there. So we actually thought maybe, that was not a point from where the blood could have leaked into the abdominal cavity. So this is something which we had noticed, and we think that maybe she will need further evaluation after she is mature enough for that. And second thing was like that area we had freshened and taken the sutures there. So when we were doing the abdominopelvic approach while the second laparotomy, there was no rent in the vagina. So it was basically the stenosis. So the main thing which was the problem was that the child was not able to put the mold which we had given to her properly. So there was some stenosis in the vagina. A sort of septum had formed, and posteriorly there was this passage. And later on, because she was putting only a part of it, so it also got stenosed, and because of the blood previously being there, there was superimposed infection, which has caused that pus, which was drained, 200 ml of pus was drained, and that was the false passage. And that stenosis separately was there of the vaginal tract, which we had to open and then put a graft there. So that previous, like the vagina which we had sutured was absolutely fine. In fact, it was very surprising that when we did laparotomy posteriorly, hardly any adhesions or any other problem was there. So that way, she was.
so you did not take any extra precaution
In the first time, we had just freshened the edges and taken the sutures. So that was the only thing which we had done. That freshening of edges was done because they were old tears, like they were not fresh bleeding tears.
Very interesting.
Yeah.
You want to?
So Dr. Rekha, just a little query that you did a pull-through procedure, but I think the cervix was patent because the vagina was full
No,
of.
we actually pulled through. What she meant was the vagina, which we could, get from the abdominal route, and that vaginal mucosa we pulled down and sutured it with the introitus.
So it was not a cervical
No,
pull
no,
through.
it was not a cervical pull through. Basically, the vaginal
Vagina.
mucosa was mobilized because it was done in the middle of night. At I think 11 or 12 o'clock we had come. So this was basically, we were not prepared for this kind of a situation that 4 centimeters of atresia would be there. And this patient had gone to the medicine side because of the diarrhea. Had she not, if she was not carrying her MRI report, probably nobody would have diagnosed and she would have just died because of all these complications. Just because she had that MRI report, we could actually
I know,
trace
very
the cause.
interesting case, like
Very nice.
wow.
He hair patient.
Having a hematoculpus rupturing,
Yes.
it's really very rare.
How long you waited after the pyocolpus got, how much time it took?
That we took after 2 weeks of draining the pyocolpus, because that time she was quite stable. We had put her on suppressant. She was receiving GnRH analog. So we had, given her that also. So when we drained this thing, we were in no hurry to do it. So we waited for 2 weeks. We gave her antibiotics. And then in that time, we motivated her that she has to maintain the passage. That is very important because she was only 14 years of age. So this thing very interesting, which I actually, when we read this ACOG recommendation, they say you give them hormonal therapy and keep it suppressed till you feel that patient is mentally mature to maintain the passage.
But most often
So-
they will come with that hematoculpus.
No,
you know,
even
they-
if they say there is hematoculpus and you keep the menstruation suppressed, it will resorb to some extent and patient's pressure symptoms will improve. So they have given many options. One is that you give medroxyprogesterone acetate 20 milligrams 3 times a day. You can give progesterone only injections also. Rather, they have mentioned even continuous oral contraceptive pills can also be given, or GnRH analogs, which we know we'll not be able to give for a very long duration. So you just basically suppress menstruation, so further blood collection won't be there. So size will not increase, and they say the response will not be very sudden, that patient will be relieved of pain and all. It may take 2 to 3 weeks for her pain to disappear, but maybe there will be gradual resorption of the blood which is collected there, and you can even delay it for 1 year or 2 till you feel that patient can.
And any other option, like besides this patient, like are you using skin graft routinely, or you use something, some other material also?
We have previously we had used amnion graft and all these, but now we have come to skin graft. Although the site is slightly ugly, but the response is very
No,
good.
we are also
So we are
using
now
skin.
yes.
But what about interseed and those things people are using?
No,
you know?
I don't have any personal experience. I think at Safdarjung Hospital we have not used it. Initially we were using those amnion graft and all, which we have given up long way back.
Very nice, congratulations.
Thank you
so much. Regarding second patient, pseudomyxoma peritoni, I'll just like presenters to tell the differential diagnosis they will think for the benefit of postgraduates there. So if you find any arborization pattern on ultrasound, what differential diagnosis will come to you?
Actually, ma'am, when we went through the review of literature, the arborization pattern was only an ultrasound finding in lung cancers and pneumonia, but not in peritoneal cavity. So this is first of its kind, which arborization we all were baffled by the imaging finding. And so they always mentioned, and throughout imaging, there was no ascites, but actually abdomen was full of this mucin, which was causing arborization. So now we know about it, what it could lead to. Otherwise, nobody knew it before.
This case was definitely a challenging case.
Yeah. ma'am.
So what all were the pointers by which we thought that this could be a malignancy in such a young girl?
Actually, because of CEA and CA 19.9, that's why we had a plan for frozen section. Then we will go ahead with further radical surgery. But her frozen section and script cytology both came benign because the pathologists say it is of low cellularity, so it is difficult to pick up on frozen and script cytology.
Yeah, I
So-
think frozen section, most often we get either an inconclusive report or a report which is not matching with the post-op report. So we should take it with a pinch of salt. If we,
Yeah, but
we
because-
cannot rely
yeah,
on frozen
yeah,
section. Secondly, this patient, like primary is the appendix,
yeah.
and that you have done a metastatictomy. This basically the metastasis you have removed from the ovaries.
Yeah, yeah, yeah.
So,
But,
and we left behind a part of the ovary, I think.
Yeah, because it was benign.
Now the CA 125 is raised. Like, what do you plan? Do you want CEA is raised? It
CEA
has
is
not
raised.
gone down.
Yeah.
So, what is
So-
your plan now?
So, ma'am, she is Nali Paris, and we have to counsel the patient regarding the fertility preserving option because it is an incomplete surgery.
Yes.
So she has to go for cytoreductive surgery and hemicolectomy and HIPEC. So that's the plan.
So,
for her.
are you planning to freeze the oocytes or
Yeah,
something? And-
Actually, this is a recent case. We are still ongoing with it. We are talking to the relatives. We have talked about all the options which are available. So they're still to decide it because surrogacy and cryopreservation are costly things. So he may not be able to afford. So life is more important. So she may.
So
go
you will be
for-
going for a completion surgery.
Yeah, that we are going. But before that, whether she wants cryopreservation
Yes.
or she wants to be followed up in CEA and then have a baby and preserve her ovaries and uterus and follow up on tumor markers, that is a patient's option, ma'am.
You must have done a thorough clinic.
Yeah.
Are these patients more likely to develop adhesions later on? What is the long-term follow-up in
Ma'am,
literature?
literature has hardly anything. I mean, they say that they have recurrence of mucin collection, not about adhesions. They require peritonectomy eventually because the mucin, even it is not macroscopic, it is microscopic. That's why HIPEC is needed. It may be in any corner of the abdomen. So,
Very nice.
So, are you giving her chemotherapy after this?
yeah, ma'am. Actually, HIPEC is not there. We've referred her to AIMS, to surgical oncology for HIPEC.
Regarding that ovarian malignancy in pregnancy, case 3.
Yeah, ma'am.
You just mentioned. Yeah.
Fetal anomalies.
No. Case 3 ovarian in pregnancy. Ma'am, you had discussed that some chemotherapy was given during pregnancy also.
No, for this patient, no.
No, not.
They were not willing. They were counseled for chemotherapy,
But they did.
but no, they were not willing. They said
So
after.
the PGs should know that there are certain chemotherapies which are safe and they can be given. in
Yeah.
pregnancy.
But
No,
what
both,
about the effect on the?
paclitaxel, carboplatin, both are safe in pregnancy.
Does it have an effect on the fetus? Long-term effect?
Long term, no, in the sense, no conjugate in the second trimester. I mean, if you are giving, it has to be in the second trimester. So it's safe. And whatever it can be because of prematurity and,
No, I'm talking about like leukemias
No.
or something because of the
no, it has not
chemotherapy.
found to cause any late, not, a lot of cases they have given chemotherapy in pregnancy and followed up, but the babies are found to be normal.
Okay.
Yeah. Yeah. Yes, at least.
Okay.
Leukocytopenia at that time because sepsis and hemorrhage can take her, can have a bad consequence. So that's important. So it may be 34 plus or onwards, anytime. If you think chemotherapy needs to be given, then we can deliver them that time and just stop it for some time. That's there. Plus germ cell tumors, then there is a problem. This one is all right. Carboplatin and the paclitaxel can be given.
Fetal medicine cases were also very interesting. I just want to know whether other hospitals can send for fetal autopsy. Because ours is not set up, so can we send? And who is doing autopsy? You are doing transfer in utero, yes.
And what about? And about the genetic testing, is it free of cost here or you're sending it outside?
Discount to them.
Okay.
So there is no Cervical in-house.
Currently, we don't.
I would like
So
to
it
break
was
the
a very
party
nice
now.
presentation.
Thank you,
I like to break this party now and start the other one.
Thank you, organizers, for giving us this opportunity.
It was
you,
very
Anita,
interesting.
Ratna,
The
and
whole
Nita.
range of cases was very interesting and an eye opener.
Thank you, Anita, Dr. Nita and Ratna for judging the So the second part of today's proceeding is the handing over ceremony. But I think before the handing over, I would just like to 2-minute presentation by our treasurer of the accounts, and then we'll begin the handing over. So I would request Dr. Upma to come and present the accounts, and then we'll start the handing over.
Thanks, Dr. Achla. Good evening, all the office bearers and dear friends and colleagues. Meri presentation. So coming to the end of our tenure in Safdarjung Hospital. So this Upma. So I will be presenting the financial statement of Aogd, what we did and what we earned, what we spent in last year. So starting from the first thing, what we got from Gangaram was around 8 lakhs of rupees. And out of that, there was a pending payment of 3 lakhs and the payment received. So it was same. So we received 8 lakhs and we have not touched that 8 lakhs. And total income generated over our tenure is about 70 lakhs 86,000 rupees. And this we got it out of life membership, annual membership, renewal membership of membership, from conference registration, online, offline, conference sponsorship, and CME sponsorship and advertisement and bulletin. So total amount 70 lakh 86,000 rupees. And the income we generated from the annual conference was 48 lakh 72,000 rupees. And out of this, around 39 lakh rupees we received from various pharma companies as sponsorship. And total expenditure was around 38 lakhs 16,000 plus 8,000 pending, as we have to pay to our WHO expert that amount. There are 25 experts. And so coming to the conference, we total made we gained 2 lakhs 55,000 2 lakh 55,000 from the conference. So then there were miscellaneous expenditures like on GST, on RTGS to Foxy, then process spot, then salaries, then electricity bill for our V3S mall, and then property tax and miscellaneous. So total came out to be 16 lakh 45,000 rupees. And so our total expenditure was, including both the conference and the miscellaneous, came out to be 54 lakh 61,000 rupees. So earlier I told you we had generated 70 lakh 86,000 rupees, and we expend out of that we spent 54 lakh 61,000. So total balance was 16 lakh 25,000 rupees. Out of this, we paid to Foxy around amount of 13 lakh, that is 12 lakh 77,000 for renewal old membership. So we have around 2,500 Aogd members, and we paid it for around 2,100 of our members this fees. Then the final balance came left with us is 3 lakhs 47,000. So pending payment is CA fees, then constitutional amendment which this time for which we have to pay 2 lakh of rupees. And then we have this also includes the WHO CME payment of 8 lakh rupees. So pending payment is around 17 lakhs of rupees. And the amount which is still pending to be received is from the conference sponsorship and CME sponsorship and the membership amount, which is coming out to be 13 lakh 71,000 rupees. So adding what we had generated, that is 3 lakh 47, and amount to be received 13 lakh 71,000. Total is coming out of 17 lakhs 19,000, and the payment pending is out of it just 17,000 7,000 17 lakh 7,000. So we have broken even, and amount left is with us is in positive, and that is the amount excluding the amount which we have received from Gangaram hospital. So that whole amount will be passing on. So we have decided we'll and we had 4 FDs. So, but they were maturing at different dates. So it was taken in general consensus that should be broken and should be started on the single day. So we have closed 3 FDs amounting to 15 lakhs. And out of that, from that, we got 1 crore 75 lakh of rupees, and still one FD is pending with us, which we'll hand over. Thank you. Over to Dr. Achla.
So I think before we begin the handing over ceremony, we have another very important thing to do. Dr. Nirja, we have among us Vice President of North Zone, Dr. Nirja. So I would like our previous Vice President, Dr. Pratima, to come and felicitate Dr. Nirja, our future President. Both were unopposed. Yeah, so now we begin the official handing over ceremony, and with the, we've had a very fruitful COVID year, and now the next year would be non-COVID year, and we have with us MAMC team led by Dr. Asmita. So Dr. Asmita, kindly come and take charge of AOGD officially. And to give the charge, I have my whole team and my chief advisor and on my, academic partners. They're all here. So Dr. Asmita. Request our Vice President, Dr. Josna, to welcome the Vice President, new Vice President, Dr. Mala. Who has helped us to run the IoT so well without any given so much help. And can I have Dr. Renu, our CME coordinator, with her here? Yeah. And our web editor. Yes. So I would like now the secretary, I think, Dr. Deepti, to be welcomed by our secretary, Dr. Monica. Dr. Deepti. Then the treasurer, Dr. Upma.
Dr. Shakun. Madhvi. Madhvi.
इधर आ जाओ थोड़ा, नहीं आ रहे तो आगे पीछे कर देते हैं। नहीं कोई बात नहीं, नहीं कोई आ रहा है, दिख रहा है। We would like our dynamic editor to welcome Dr. Madhvi.
New chairpersons. I think Dr. Shivani and Dr. Kiran are here, so I would like them to come. Dr. Minali, so we have 3 new chairpersons who are there. So I think yeah, yeah, yeah. Dr. Shashilata, I will give over to Dr. Kiran. Nee? I saw Dr. Shashi. Yeah. From the old to new. We've had a very good team. All the chairperson have been really good and they worked very hard to make it a good academic program throughout the year. Thank you, Shashi. And then we have, I think, Dr. Asmita will do the honors for Shivani because Seema is not here. She is the new chairperson for the Public Awareness and Cervical and Breast Cancer Awareness Committee. No, Rural Health Committee, sorry. Public Awareness and Rural Health Committee, Dr. Shivani. And she's been working very consistently for public health with me through NARCHI, through Aogd. And we have with us Dr. Minali Mani. And I would like Dr. Sunita Malik to no, it doesn't matter, one chairperson to another. She is the chairperson for cervical cancer and breast cancer awareness. So oncology chairperson is a very well suited person to give it. And Dr. Minali already is working in this field so much. So now I hand over to Asmita to, over from my side now, all yours. Please, Renu. Dr. Sharma, आप भी आ जाइए. Dr. Nisha, आप भी आ जाओ. I know, हमारे handing over में हमारे साथ old VP, new VP, Foxy का Eurogynae का chairperson. क्या? आजा. अब देखो पीछे नहीं आ रहे, सब नहीं आ रहे सब ना, कुछ लोग बैठ जाएं. सब आ रहे हैं. वेरी गुड. अंजलि को भी फेलिसिटेट कर दो. अंजलि को भी कर दो. अंजलि को लोग ज्यादा हो गए. नहीं बस 1 मिनट बोलूंगी. So I like to also thank everybody who's come and joined, and also LifeCell for being the academic partner for this program. And Sumitra, I think you are associated with LifeCell for your. So I would like to say you to say a few words for them. Come.
वो तो है मैम, बट उसके WhatsApp में जाएगा ना.
Basically that we've received a lot of support from them because patients are coming from that category that they'll not be able to afford those kind of prenatal tests. So they've been able to give us a reduced rates and all, so that has helped us in being able to offer those services to these women at a nominal cost, and they've been supporting us in our academic activities also.
I would like to ask Dr. Upma to personally thank LifeCell because she's the one who coordinated with them.
So I just want to add that their reports are very reliable and they are very, cost effective also. So they're the right choice whenever we want to get any prenatal testing done. And again, I want to thank the LifeCell for sponsoring this event. And I invite you all to come for this refreshment.
Take only one photo with me. Ma'am, please.
वो सर्च ही नहीं हो रहा मैम, वो WhatsApp के डॉक्टर. हाँ मेल करना पड़ेगा, बट इसमें मेल किसकी करेंगे, हमारा लैपटॉप नहीं है ना. मैम सब जा रहे हैं.